Anybody know what this is? It's a spider. And how this relates to what we're doing is, I don't know if you knew it, but on every acre of land, there's roughly 1 million spiders. At your house, in the big cities, there's 1 million spiders. And how this relates to what we're talking about is lots of people have diverticulosis. Very few people have diverticulitis. And the ones that do, you know, it's just like spiders. They're all around us. Most of the time we don't know about it. Occasionally they scare us to death. On rare occasions they bite somebody or sting somebody and it can cause a problem. Okay. Now, what is diverticular disease? Diverticular disease is an abnormal sac or pouch protruding from the wall of an organ. Okay. The true diverticulum is composed of all layers of the intestine. A false diverticulum, or what's called a pseudo-diverticulum, lacks a portion of the normal intestinal wall. The usual diverticulum of the colon in humans is a pseudo-diverticulum. Okay, this is a common condition of the Western society, modern Western society. It started after the beginning of the Industrial Revolution. If you go back and look at all the medical museums in Europe before the Industrial Revolution, there are no signs of it. It's not there. And they have thousands and thousands, so you would anticipate that they ought to have some if it was there. Now, the process of roller milling wheat flour was introduced in Europe about 1/4 century before the first appearance of diverticulosis, first observed about the first portion of the 20th century. It is thought that the decrease in consumption of unprocessed cereals and the increased consumption of sugar and just meats by the general population are factors that are responsible for this. Over the last 75 years, the amount of fiber consumed in the United States and Western Europe have decreased considerably, and the incidence of diverticular disease has increased greatly. Age also plays a role in diverticulitis. It's rare to see it below the age of 30. I've seen one person 26, one person 28 in there. Now, in this room, how many do we have today?
59.
59. So roughly 40% or 24 of the people in here have diverticular disease. And you may not even know that you have it. Now, I can say that I don't have it because I've had a recent colonoscopy, so I know I don't have it in there. Now, if we make it to 80, 65 to 75% of us will have it. Okay? Now, where is it located? Diverticulosis is more frequently involved in the sigmoid colon, followed by the descending colon. The muscular wall of the sigmoid colon is often thickened or very hypertrophied. The sigmoid colon is a portion of the colon that's the smallest. Now, this is the colon, this is the rectum, this is the sigmoid right through there. That's the most frequent area that it happens. This is the descending colon, and you rarely see it through here, but on occasion you can. In there, and occasionally somebody will have a diverticulum, a single one or two over here. Now, how does this happen? Diverticular or herniations of the mucosa through the muscle of the wall. Okay. All diverticuli occur where the arteries come into the colon at this point. They're all located on the mesenteric side of the colon. That's the side where the blood vessels come into. And if you see a real picture of it, of the colon, it's where most people have fat that you can see coming up from the blood vessels up to the bottom side of the colon in there. Because they're located next to the arterioles, this is why once in a rare time people come in bleeding from this, because they get it real irritated and it wears into that blood vessel and it bleeds and bleeds and bleeds and bleeds. Okay, you look at this as a cross section through colon, piece of colon, and see where the arterioles come in, right there. What happens is that there's a lot of pressure in there, and the pressure pushes through. We're going to talk about why that happens. When there's a large amount of fiber in your colon, i.e. you've eaten a lot of fiber, a lot of fruits, a lot of vegetables in there, the pressure required to move it through is very small. And the reason is, like, if this is a colon and it's full of bowel movement, all it's got to do is squeeze a little bit like that, and it pushes things forward. Okay, if you only have this in there and it's that big, it's got to squeeze all the way down to there, generate a lot more pressure, and then where you have the weak spots that we showed up there, it eventually blows out the inside lining. Now the inside lining moves around a lot, but it will eventually make that pooch out through there. Okay, like I said, with the decreased amount of fiber in today's diet, there's decreased content requiring increased pressure to move it forward. And this is what is thought to cause the diverticulosis. The diagnosis of diverticulitis, which is when you have diverticulosis and it gets inflamed, is usually people come in, they have left lower quadrant pain, their white count is elevated, and most of the time we can get a CAT scan, an MRI, ultrasound are the main ways of diagnosing this. Now, depending upon where you are and what the skill level is, or the preference of the radiologist and the technicians, depends upon what you get. There are some places that they do almost most of their tests with an ultrasound, and there are others that are MRI. The majority of people in the United States, people come in with that pain, they get a CAT scan. So if you were to come in the ER, your white count was up, you're hurting the left lower quadrant, you're over the age of 50, you're going to get a CAT scan. All right. This is a picture of diverticulosis in the sigmoid colon. There's one, there's one, there's one, there's one. You know, people are looking over here, there, and there. These are small. Here's some more pictures. There's one, there's one, there's one. That's the lumen of the bowel. I've been in some people that the diverticular openings were bigger than the colon. And sometimes when we do colonoscopies, we get in there, we don't know. I mean, we have to be very careful because they're all the same size. And if some of the people haven't prepped real good and there's liquid stool still in there, we have to be real careful, because if you go through there, you can pop a hole, and then that makes it a bad day for everybody. And I've even read of some people that just going in and doing a normal colonoscopy, not having that happen, that sometimes the pressure of putting the air in there has actually popped people in there, and they've had to run up and have surgery or some kind of treatment for it. Fortunately, that's extremely rare. Like I said, I've never seen it. I read something from a surgeon up in Milwaukee who's at a big school that they do lots of this. He says this happened to him twice in 30 years. And he says he hadn't seen it happen with anybody else, because he would be like me, the ones that would fix it from people who aren't colons that do this. Okay, this is a barium enema. Sometimes before we got to all the CAT scans and the Casey, sometimes we get these on people. If you come in and you have the pain, we want to get this x-ray. You look, you can see little pockets down through there. There's one over here on the right side. See it? Okay. Here's some more. This is a side view. You can see the pockets coming out there. You see, look, real narrow. That's where it's coming through, and it pops out. One of the reasons that people develop problems with this is that they get constipated. Now, as long as your bowel movements are nice and soft, what's going to happen is it's going to come in, it's going to move in, and it's going to move out, and you're not going to have a problem. If you get constipated, what happens is that area gets clogged up. All the bacteria that's in our bowel movements, they keep growing and multiplying, and all of a sudden they start expanding that. It expands it out. It decreases. It makes it where the veins can't empty. Arterioles keep pumping in, and next thing you know, that area has died and it's busted. And as we all know, bowel movement needs to stay in the bowels or in the colon and not get outside. Okay. Here's another picture. Look at all these. So one of the points I want everybody here to get is drink plenty of liquids, and you need to make sure you don't get constipated. Okay. Part of the thing is that we need to increase our fiber if you're not getting it. I'm going to have some handouts I'm not endorsing the company that makes them. Andrea's showing them back there, but it does have a brief discussion about it. And what I like, Andrea, if you'll open it up on the very back, there's a little fold out there. On the very back 2 pages is a pocket guide to fiber. The ideal thing is, to me, is for you to buy the food at the grocery store and eat it. Don't pay that company or some other company to grind up a seed or to make something chemically. I mean, literally, that's all they're doing. So if you eat what they say back there, you're going to eat healthier, your bowels will work better, and hopefully you won't be coming to me for some of these things I'm going to show you here in a few minutes. Here's another one. You can see some pockets there, and right there. That's not as big as it's supposed to be. What happened there is that they had a bunch of infections and it's narrowed down. And if you go back 30 years ago, people would come in and we would get a barium enema and we didn't know if it was cancer or diverticular disease, because people would have flare-ups and they either died or they got better. And then finally they might come in to the medical center somewhere where they'd get an x-ray. I mean, literally they did in there. And if they got better, this would scar down to a point that sometimes it would actually block them up. But when we got the x-ray, we couldn't take it. Looked exactly like a cancer that it had narrowed it down. Here's some more. See the little pockets there. Okay. Diverticulitis. This is inflammation of the area around it secondary to a perforation of one of the diverticulums. The sigmoid colon is the highest incidence of diverticuli and diverticulitis. Now, people come in with diverticulitis, usually they've had a little perforation. A lot of times, if we know you have diverticuli, you call your family doctor. He knows it, he sees you, you're not real tender, but a little bit. We put you on antibiotics by mouth, and you get well, and you go home, and then hopefully you change your diet and get back better in there. If it's a little bit worse, you might get admitted to the hospital and get some antibiotics. If it's really bad, you get admitted and you do some of the things I'm going to show you later, which I really don't want to do on you, and you don't want me to have to do it on to you, but you're happy if I absolutely have to. Okay, signs and symptoms vary. Left lower quadrant pain and tenderness, usually, like I said, it can be mild, which you can be treated as an outpatient, or very severe. Pain can go into the left groin, suprapubic area, or into the back. You have changed in bowel habits. Even though you may have made a hole in it, sometimes people get constipated after this because nothing wants to go by the area of inflammation, or you may have diarrhea because it's trying to get it by it very fast. Chills, fever, you can have urinary urgency. On rare occasions, the diverticular disease can actually make a fistula into your bladder. And I've had people come in complaining that they're passing bowel movement with their urine, or they're passing gas when they sit down to urinate. It happens. Rare to have rectal bleeding from diverticulitis. Occasionally, if you have a big abscess, you can have a palpable mass down there. And in some people, if it's really bad, nothing will go by. They'll start getting real distended and they'll vomit. Be very nauseated. Okay, there's a classification. Stage 1, pericolic or mesenteric abscess. These can be very, very small. The very smallest of these can be treated as an outpatient. You can have a walled-off pelvic abscess. That's when it's busted and it's starting to become a lot bigger in the inside. You can actually have purulent peritonitis, where you have an abscess but it's leaking out a little bit, and there's some people that actually there's a hole that big around and bowel movement is just pouring out into the abdominal cavity, which is not good. We don't like to see that. Thank goodness it's a fairly rare thing to happen. Okay, uncomplicated diverticulitis, no free peritoneal perforation, there's no fistula, there's no obstruction. Like I said, usually treated with antibiotics. Early, you can give them by mouth. If you have pain or you're more sick, IV antibiotics. When we get through and you go home, most of the time we get you well, we send you home. we need to bring you back and make sure it's not something else like a cancer. Okay. Most of the time, if you've been admitted to the hospital, we would have gotten a CAT scan on you. It will tell us that it's diverticulitis and not very bad. If you have multiple attacks, used to they say if you were under the age of 50 and you had 2 attacks, you needed to have it done. Now they're talking about 4 or 5 attacks where you just kind of get sick, come in, the antibiotics take care of it. Nowadays they're talking about if basically it's treated by mouth, probably not going to operate on you. We're going to try to get you to change your diet a little bit, make sure that this doesn't happen to you again. Most people, if they have to be admitted to the hospital 4 or 5 times or something like this, then we have to talk about operating on it. Complicated, has a big abscess, usually confined to the pelvis. Most of the time that I've gone in, you get at least a cup of pus out. It can be a whole lot more. These people have significant pain. They usually come in with a temperature of 101, 102, and their white counts, a normal white count in this hospital, I believe, is 11,000. Usually it's 17, 18, 19,000, which is a sign of significant infection. Okay, if you look right here, see those look like bubbles? That black here, that is an abscess. Okay, don't like seeing that. Okay, treatment. If the abscess is less than 2 centimeters, and a good way to say what 2 centimeters is about 3/4 of an inch. If it's less than that, we put you in, we put you on antibiotics anywhere from one to 3 weeks. Most of the time that will resolve. Used to, they said if you had this, then you definitely need to have to come back and do it. Some of the literature now says that half the people don't need it. So instead of taking a lot of people to surgery to start off with, after 1 episode with a small abscess, we try to put them off, and we're finding out that 50% of the people, we don't have to take them to surgery. Okay. Now, if it's greater than 2 centimeters, we have to drain it. And I've seen them as much as 10 and 12 centimeters. You can imagine how much infection you get out from there. The preferred method is percutaneous. The radiologist, a lot of the times, either using an ultrasound or a CT scanner, can put a needle down into the area and drain it. Now they have some restrictions for that because they can't stick it to an area that's where it's real close to some blood vessels or nerves, because they don't want to hit the nerves in there. If they can't do that, then we have to talk about doing surgery, and I'll show you a couple of pictures of that later. Put them in IV antibiotics, elective surgery after the abscesses. Some require emergency surgery if you don't improve very often. If the person continues to get worse, even though we're giving them the antibiotics, we pretty much know in the majority of people antibiotics that will take care of this. And if they're not responding after 4 or 5 days, so say you came into the hospital with this, we put you in the hospital, we would give you IV antibiotics, and after 5 or 6 or 7 days, we would probably repeat another CAT scan, even if you were getting better, to make sure that the antibiotics aren't covering something up. And about maybe 1 out of 6, you look like you're getting better, but inside it's getting worse on that. So also with some people, used to, when I first started training 30 years ago, if you came in and you had air on the x-rays, you went immediately to surgery. Nowadays, if it's a little bit of air, we treat you with antibiotics, and about 90% of those people get better, and we can bring them back later to do an elective surgery, one-time surgery. Okay, a fistula, connection between the sigmoid colon, the skin, the bladder, the vagina, or the small bowel, are frequent complications. The most common that I've seen have been to the bladder and through the vagina. And some of those people come in, they say, well, I hurt down here for a while, and all of a sudden they start having bowel movements through their vagina. And the way you treat that is you basically go in and resect that area and then just stitch up where the connection was. And that will usually heal that up without much of a problem. The small bowel, you resect that area. Depending on how big the hole is, you may resect that whole piece of cut out that whole piece of intestine, or if it's a small hole, you may stitch it up. Same thing with the bladder. You resect it, you stitch it up. Usually we'll have a urologist to come in and fix that with there. And I've never seen one to the skin, and hope I never do. That would be something that's pretty nasty in there. All fistulas have to have surgery to fix them. On occasion, you will see somebody who is elderly with multiple medical problems that you may just go in and give them a colostomy and not fix it, because that's big time major surgery to try to fix it, and they may not be able to withstand it. Okay, peritonitis. This is caused by perforation, and you have colon material going into the cavity and it's not sealed up. A lot of the colon, even in skinny people, there's fat around it. There's little things that flop around, and we have what's called the omentum, which is a fatty blanket that kind of hangs down. And when there's a hole, it goes and tries to get around it, and the body tries to stick it together with that. But it doesn't always happen. If it busts into the peritoneal cavity, you can wind up and get sepsis, which means you're very sick, you're having a huge inflammatory response, and if you don't do something about that fairly soon, you'll wind up and die. Treatment of this is removal of the area of rupture and a colostomy. With the colon, if there's a bad infection, you cannot sew it back together. If you do, it's just going to break down and you're going to go back again. On occasion, I've seen some people perforate one diverticulum, gone in there, seen it, and have been able to sew it up. But the person said, this happened at 4 o'clock, they were in the ER by 6, and we were in the operating room by 8. But that's highly unusual, because most people think, oh, I just ate something bad. They go home and take some Pepto-Bismol or something else. And by the time they come in, it's usually a good 24, 36 hours away, and the area is all inflamed. And here's a picture right here. Diverticulum had ruptured here. Bowel movement goes all out in there. We go in, we cut that part out right there. We free up under here. And then you can do a couple of different ways. This is the colostomy. Sometimes we do what's called a mucus fistula, where we bring the end out here, up here. Some of the time you can do that if you have enough colon below where it ruptured. You bring it up. Most of the people I've seen lately, when I've had to do this, and there's not enough, and we do what's called a Hartman's pout, where we sew that up and just drop it back in. And then most people, somewhere between 4 and 6 months after that, they've healed up enough, we bring them back to surgery and hook them back up together. Okay, now, there are a couple of myths about diverticular disease. You can eat anything you want. Okay? You just have to chew it good. Okay? There are people that tell you that you can't eat nuts. You can't eat strawberries. You can't eat corn. If you chew it up good, it's not going to cause a problem. Now, the one thing that you might want to be careful about eating is popcorn, because those hard husks, they may cause a problem, but anything else, if you chew it good, you should not have a problem with it. Okay? Because if you grind up a nut till it's powder, how's that any different than eating mashed potatoes? It's not. Okay. Any questions?